Hello, everyone, and welcome to the 2025 Best of Lung Cancer Science Special Edition podcast from the Society of Thoracic Surgeons, where we examine the science shaping the future of thoracic surgery. I'm your host, Dr. Erin Gillaspie, and today we're discussing the best new science from the 2025 World Conference on Lung Cancer, or WCLC, this year's largest global gathering of lung cancer experts and what it means for thoracic surgeons. Joining me today is Dr. Leah Backhus, a leading voice in lung cancer surgery. She is the Thelma and Henry Dolger Professor of Cardiovascular Surgery at Stanford and the Chief of Thoracic Surgery at the VA in Palo Alto. I'm so glad you're here with me to unpack some of the biggest studies from the perioperative immunotherapy, ctDNA, to surgical decision-making in GGO-dominant disease.
Well, thanks so much, Dr. Gillaspie. It's my pleasure to be here and excited to kind of go over this little recap.
Leah, you and I were both at this amazing conference, and we've been following the latest data very closely. Let's start with sort of big picture take home. When you think about the WCLC 2025 as a whole, what really stood out to you as maybe the most impactful science, or what common threads did you see woven throughout that stood out to you that thoracic surgeons should be paying attention to?
I mean, I think it's important to kind of keep it within context of it being such a massive meeting, and it can honestly be a bit overwhelming. So I'm happy to sort of stay in my surgeon lane, and really that was the eye that I was using as I was perusing the presentations and sessions to try to attend. I think the ones that stood out the most were kind of updating surgical data from some of the peri-adjuvant trials. There are some technical discussions with regards to lymph node dissections and whatnot. A few on PROs, which sometimes we fail to prioritize when it comes to thinking up our surgical treatment plans, et cetera, for patients. So, but I think those are the main ones, and mostly dominated by the peri-adjuvant trial data.
Absolutely. Absolutely. The peri-adjuvant, perioperative, neoadjuvant, I mean, that landscape is just absolutely exploding.
It is. It really is.
All right, so let's talk about a few of the really buzziest studies that came out of the meeting. And we're going to kick things off with Skyscraper 05, which was a phase 2 study using a new drug. So introducing yet another drug for us into the neoadjuvant space, this one called tiragolumab. This was combined with atezolizumab and chemotherapy in locally advanced non-small cell lung cancer. So to kick us off, Leah, I think a lot of people probably aren't super familiar with this drug, tiragolumab. Would you mind expounding or giving us just a little brief highlight on what is this drug? It's in a class of drugs called TIGIT. It's an emerging class of therapeutic options. Tell us a little bit more.
I'm happy to. Obviously, you know much more about this than I do, Erin. But anyway, for the less indoctrinated like myself, TIGIT is an immune checkpoint molecule that's expressed on T cells and NK cells, and it really represents this new or potentially new molecular target for some of our treatments. Right now things are largely just dominated by PD-L1, and this offers another opportunity to either could be combined with some of our best therapeutics that we have out there, or to be used as monotherapy. Of course, this particular trial was in combination with the atezolizumab. So I think for our audience, like I said, for myself included, the main thing is to just emphasize that it's a novel target.
I love that. I think that's a perfect summary. And if any of you really wants to hear the nitty gritty, heavy details, dive down into the notes from the recording, and you can see another little link to hear a little bit more about TIGITs. But enough about TIGITs. Let's talk about the trial. So let's dive in. Tell me a little bit about the study design. I mentioned it was a phase 2, but really it was a 2 cohort with 2 slightly different treatment arms that were taken through. Talk to me a little bit about that and the results of this trial.
Yeah, so the study population, well, it was phase 2 trial, as you'd mentioned. Study populations were stage 2 through 3B. So those are our surgical patients, all in the mid stages. 2 treatment arms, both were interventions. One was the tiragolumab and atezolizumab. The other was the tiragolumab, atezolizumab, and chemotherapy. So basically plus versus minus chemotherapy, followed by surgery. And then you would go on to either have adjuvant chemotherapy or adjuvant tiragolumab, atezolizumab. So honestly, these trials can be very complicated to kind of keep the study structure and schema straight in your brain. And of course, that offers more challenges when it comes to trying to compare results from one study to another, which we're always told not to do, but yet we always do that. In any event, The conclusions of this study, or what they found predominantly, was that there was improvement in MPR and in PCR in the combination tiragolumab and atezolizumab and chemotherapy. Tiragolumab and atezolizumab alone was terminated early in that particular treatment arm due to changing landscape. And I honestly don't know what that changing landscape was. So I don't know if you have any more insight, Dr. Gillaspie, since you have your finger on the pulse, but that was not clear, at least from the presentation. So I do think that it basically showed promise, and as a lot of phase 2 trials do, it's just, one click away from feasibility, but just to look at the safety profile and whatnot. And I think that this is a promising combination that definitely deserves some further exploration. Do you have any more insight there as to what the landscape change was specifically?
Yeah, so there's always a lot of concern, especially as you head into these sort of later stage arms, if you're not including sort of that backbone of known treatment effective combination, right? So we know that chemoimmunotherapy is effective in the neoadjuvant setting. We know that chemotherapy alone is effective, not as effective as we'd like it to be, but taking that out altogether and just having this combination, I think there's some concerns with some of the stage 4 studies, maybe not having as much response, and some concerns that potentially we could see some progression in that neoadjuvant space, which is one of the biggest concerns we have as we move these drugs, right? We don't want to lose an opportunity to treat patients. And so there's always a lot of consideration. Others, they're putting these trials together and these combinations. Can we get chemo-free regimens? And in some cases, we might be able to with some of the targeted agents. With some of the newer combinations, maybe, but it's still sort of an evolving area, and the metastatic space is heavily influencing how we move these drugs in, and some of the results of those trials are actively influencing arms, like we saw with this trial, and actually like we saw with Checkmate 816 as well, where the ipi-nivo arm, similar to this one, was actually closed early because of sort of this evolving landscape of saying, hey, we have other trials coming out that are showing we have a highly effective combination. Should we be doing this without the chemotherapy?
I think that's an interesting point that you bring up, which is that sort of kind of landmark trials that are done in this era of immunotherapy. We're all in this rather shotgun approach happening all simultaneously. So you didn't really have as much influence of one trial influencing the other. And you did have equipoise to be able to throw out all sorts of regimens because we didn't have any specific data that declared one regimen superior to another. And then now, because the landscape is starting to get a lot more crowded with a lot more data, now it becomes even harder to try to come up with these schema that allow you the equipoise to be able to go ahead and move forward and not close early or not have trouble accruing, etc. So it's definitely an evolving target. Talking about targeted
Yes.
therapy. Yeah, so.
Absolutely. Absolutely. And what's interesting with a lot of these trials too is I think, a lot of them are being born out of this desire and this drive to really find the highest opportunity for pathologic complete response, right? When we were seeing these patients in the Checkmate 816 that are now out 5 years with a path CR, 95% of them are alive, really, almost all of them cancer free. That's just completely extraordinary. And so, we're continuing to see all these drugs migrate into that earlier stage space. We're seeing in this trial, again, phase 2, it's early. In cohort B, we have some data that shows us the MPR rate's 51%, PCR is 29%. So driven up a little bit from our conventional chemo IO. And importantly, you mentioned this earlier, surgical data, right? And so they're able to show that we can deliver the addition of the TIGIT without significant increased morbidity, no increase in mortality, which is so critical, especially as we introduce drugs that we haven't really had before in the neoadjuvant space.
Yeah, because kind of going back to that comment about equipoise, right? Because the periadjuvant space is our playground as surgeons, in terms of where we have the most bang for our buck as far as effectiveness goes, you've got to convince surgeons, right, that it's okay to let your patients go, for lack of a better word, to get treated and have them come back. And everybody holds up the 20% attrition rate for all the neoadjuvant trials sort of collectively. It depends on what your bias is, right? Some people view that 20% as saying, oh, that's not very much. And actually, you know what? It's pretty comparable to the, non-intervention arms, et cetera. Compared to historical controls, it's actually amazingly good. So it depends on how you want to look at it. You could also look at it and say, actually, this is pretty fantastic. And honestly, this is another way to have better patient selection, to know that we're really operating on the people that we're going to be able to help the most with our intervention, right? So yeah, the getting the equipoise and getting the safety data is critical to even opening the door, just cracking the door even a little bit to convince surgeons that if you give your patients induction therapy, it will be good for them. And it won't make your surgery too difficult.
Yes.
That's that's the other kicker.
Absolutely. And, unquestionably, as we move more and more drugs into this earlier and earlier space, in times of uncertainty, defaulting to an open case if you're not sure, if you're running into fibrosis, I think that's an important thing we should always circle back to and emphasize. In a lot of these trials, if we look back, especially to the early trials for neoadjuvant perioperative, two-thirds of cases were being done open because nobody knew what to expect. And so delivering a really high quality surgery in the safest way possible is really, really critical as we continue to head into this unexplored territory.
Absolutely. I think that it would behoove us to be more discerning in terms of how we view the data, but also to be like yourself, very much involved in study design and at the inception of all these studies to come up with the appropriate surgical outcomes to look at. Aside from Checkmate 816, like there really aren't any other good studies out there that have an amazing granularity of their surgical data. It's sort of like they had surgery in air quotes and it went well, or you know what I mean? But surgeons want to know, well, what was the EBL? And obviously they talk about conversion rates and things like that, but what did the nodes actually look like, and what should I do? What's an acceptable rate of conversion? All these things that unless you get surgeons at the table helping to design the studies is never going to get answered within the confines of these trials.
Absolutely. Absolutely. So, for all of you people putting together trials out there, please, please, please tap your friendly neighborhood surgeon to
Come
join and
talk
help
to us.
in.
Come talk to us. We're available.
All right, so let's move out of our skyscraper territory to another very, very exciting neoadjuvant trial, the Neoadora. This is the year of Neoadora, I think, long anticipated trial. First major presentation came at ASCO, where we learned about the PCR and MPR rates. And now, just a few months later, World Lung, we have our next major update, and it's the MRD analysis. As a reminder to our listeners, please check out our ASCO edition of this podcast where Brendan Stiles and I chat about the details of the Neoadora trial. As a little brief reminder, 3-armed trial, randomizing patients 1:1:1, OC alone versus OC chemo versus chemo placebo in the neoadjuvant setting, followed by surgery. So Leah, tell us about the updates. What are the MRD results? Talk to us about what they shared at World Lung.
So, I mean, just to talk a little bit about MRD in general, I love this because this is kind of where I do most of my research is in post-treatment surveillance. And obviously, for the most part, that's all predicated on just imaging, right? But the whole concept of MRD is so important as an emerging concept and a new tool that we have to help come up with more tailored treatment regimens for patients, identifying the people who are the highest risk for recurrence so that you can go ahead and treat them more aggressively, save patients from inappropriate treatment that they otherwise really don't need because it's not going to be of any benefit to them. And so it's more than just stratifying risk. It's really more about tailoring treatment. So MRD is great. I mean, I don't know that it's totally ready for prime time. I mean, I think it's great that it's included in many of our clinical trials data as it should be. So I think it's fantastic that it has been incorporated relatively consistently in these trial designs. So anyway, with regards to this particular study, I think one of the things to point out is that this is a tumor-informed assay. And so one of the things that I would like to emphasize there, of course, is the need for tissue prior to, which everybody, for the most part, agrees that it's good to have tissue. It's good to get all your molecular upfront so that you can, figure out what's the best regimen for your patient. But this is yet another use for that pre-surgical, pre-treatment tissue acquisition is that you can then go ahead and have your tumor-informed assays looking for the MRD afterwards. And so basically they found, about 77%, I think, were MRD positive at baseline, which is pretty high, actually. I thought that was high, but maybe it's higher because, this again is a little bit skewed towards a bit later disease. We know that MRD differs in terms of its prevalence based on stage at presentation. So obviously with earlier stage having less prevalence of MRD being detected at baseline. But then what they found was that the post-treatment MRD compared to baseline was reduced significantly so, really in all treatment arms, but the biggest effect seen in the treatment arms with osimertinib compared to the chemotherapy alone. So not earth-shattering with regards to that, the fact that you can reduce the ctDNA burden in patients by giving them induction therapy. But I think it just underscores the importance of it, and it gives us more information in terms of how prevalent and therefore how useful it'll be as we try to apply these principles to larger populations.
Absolutely. I love that you highlighted that this was a tumor informed assay and highlighted the tissue versus blood, because in this trial, they actually tested for both, right? And so they had, I think 189 of the 210 patients had their tissue, and they also had plasma. And to be able to look at the different assays to be able to help determine, which was going to be more predictive in determining MRD positivity, and the tissue-based assay was much better. And so, really sort of highlights that tissue is going to continue to be an issue. Biopsies are going to be critical, making sure you get enough for not only, finding your mutations, but really, I think, we're going to have to be better and better stewards of tissue all the time. And really the prognostication, and to your point, escalation and de-escalation of therapy at appropriate timelines, I think to me was one of the most exciting parts of some of these studies, because a lot of the treatment courses have been prescribed a little bit arbitrarily, some of it based on the metastatic space. But 3 years of osimertinib, is that right? Is that wrong? Should we
Yeah, is
stop?
that magical? We don't know.
We don't know. There's trials now moving it out to 5 years, and people saying, holy cow, maybe we should be thinking about 1 year instead if we can clear things. And so,
Mhm.
also having, the ability to check this throughout the treatment cycle to make sure that post resection as well, we're seeing that decrease and maintain that drop, I think is really, really exciting.
Absolutely. And I think if we're able to combine MRD with potentially other means of earlier detection for recurrences, then that'll be even better. So you certainly don't want to commit someone to 3 years worth of treatments that are expensive. There's financial toxicity. There's all sorts of reasons why we should not overtreat people. But, especially as we're talking about these sandwich perioperative regimens, we still don't know how much and for whom.
Absolutely. I'm also really appreciative that you made mention that we're not quite ready for prime time yet, right? All of this stuff is still being tested in the clinical trial setting. So we are not recommending that everybody start testing all of their patients in the surveillance period before surgery for minimal residual disease, circulating tumor DNA. This is still an evolving field, evolving platforms. Not all platforms are created equally. There's tumor-informed assays. There's tumor uninformed assays that are a little bit more sort of generic and broad. So stay tuned. More updates coming on that front, but not quite ready to bring into practice yet.
Yes, absolutely.
Okay, so sticking with our theme, we have a neoadjuvant theme. Really, we're hitting it hard. So believe it or not, guys, there is more fun information coming out of the Checkmate 816 trial. We've talked a lot about Checkmate 816 in the past. Please, again, don't hesitate to jump over to my conversation with Brendan Stiles for our ASCO update. Also, the Thinking Thoracic podcast with John Spicer, where we go over that study in huge detail. Leah, at World Lung, we are looking at it through a little bit of a new lens. And so this time the analysis is specifically by surgical outcomes, which I think is a really nice consideration as we think about some of the surgical details. So, type of resection, degree of resection. Talk us a little bit through some of those results that they shared at World Lung.
Well, I think as you and I were chatting earlier, extensive resection is a big deal, right? Particularly when you're talking about pneumonectomy versus a lobar lung resection. And we just know that clinically, anecdotally, that it's a huge order of magnitude difference to do a pneumonectomy in somebody, even of the average surgical risk versus doing a lobectomy, right? Like we always consider that kind of independent of that patient's surgical risk. And if you look at the super historic chemotherapy only trials, right? And that the intergroup trial demonstrating, really adverse outcomes for pneumonectomy patients getting induction treatment, that was sort of the no-fly zone, like if they needed a pneumonectomy, you really should be considering not. That was the takeaway from that, right? And I think the corollary to that has been a lot of these periadjuvant trials which have demonstrated different outcomes for patients undergoing pneumonectomy versus lobectomy, with some trials demonstrating still worse outcomes in the pneumonectomy group. But the other thing that I would point out here is the fact that I think the offshoot of that is a lot of other trials who've completely shied away from pneumonectomy patients and just not including them a priori, right? So that if you've got pneumonectomy as part of your exclusion criteria, that just further diminishes our ability to be able to make any assessment about whether or not it's truly appropriate or inappropriate. And even if you do that, I know we don't like to tout it out there as a means to avoid pneumonectomy by getting an amazing response to your induction therapy, but we know that that can happen. And if you can convert someone who needs a pneumonectomy down to bilobectomy or regular lobectomy or sleeve lobectomy or something like that, then that's going to be huge for that patient. So I think that this particular abstract is necessary in this space. It's using Checkmate 816 surgical data, which I already mentioned. I love, and of course that's because we've got Dr. Spicer in there, Dr. Mitsudomi, like helping to lead the way. So anyway, without going into all the details of Checkmate 816, suffice it to say that this abstract really was just looking at surgical outcomes as defined by the surgical approach, whether it was minimally invasive or open, and the extent of resection, whether or not it was lobectomy versus pneumonectomy, and then of course the completeness of resection and whether or not an R0 resection had been accomplished. And basically there was benefit found in all groups. And I should say that there was benefit in the intervention arm independent of whether or not your surgery was done minimally invasive, open, whether or not you needed a pneumonectomy, and even whether or not you had an R0 resection, which is pretty impressive to be able to say that your results are durable and persistent across all of these various, very heterogeneous circumstances. So especially as we're talking about sort of the safety with and confidence with which a surgeon may be able to approach someone who's had a whole lot of induction therapy. If you feel that the patient needs a thoracotomy, do your thoracotomy and do a safe operation, and there's still going to be benefit for them. Likewise, if they need a pneumonectomy and everything else lines up appropriately, don't shy away from offering that patient a chance for curative surgery.
Absolutely. I love that summary because you're right. Really, in the wake of the INT-0139 trial, it was really drilled into so many of us that multi-station N2 is off the table, pneumonectomy is off the table. I think that trial had like a 26% mortality rate for pneumonectomies, which has never existed in any other trial. It was one of these flukes that just sort of didn't make sense, right? But that's what it was. It was in the trial. And so we were sort of stuck with this data for a long time. And you're right, some of the trials did completely exclude pneumonectomies. AEGEAN, I believe, was one of the trials that said, hey, if you're planning a pneumonectomy, we should randomize them into this trial, but a lot of the trials allowed for them. So Checkmate 816 did, Keynote 671, I believe, allowed them as well. I know all the Nadim did. And actually, Europe tends to use pneumonectomies a little bit more aggressively. We see higher percentage of pneumonectomies coming out of their cohorts of enrolled patients. And the thing that I loved about this result and this presentation is that they highlighted that not only did those patients do okay, so the perioperative morbidity mortality was completely acceptable, but also they did really well for the long term. Actually, some of their survival rates in the pneumonectomy patients were better than anybody. And that was a thing that always was sort of wrapped into some of the old data, right? Is that it shortened
Yeah.
lives, it was high mortality. And so I think these trials are starting to show that we can do very aggressive surgeries very safely for these patients.
Absolutely. I think that your sound clinical surgical decision making should remain intact. Just know that you're not going to be harming your patients because that was the message, as you reiterated, that we had ingrained in our heads. As long as you're using appropriate, oncologic principles and doing a safe operation in the right patients, you're going to actually do them a huge service.
Absolutely. Absolutely. With really incredible survival rates, as we're seeing coming out of so many of these trials.
Absolutely.
All right. So we're going to completely switch directions. We are going from locally advanced drug treatments thrown in, multimodal treatment regimens to GGOs.
Yes. Yes, we're away from the MABs and IBs, and now we're talking about the ectomies.
That's exactly right. So pure surgical trial. It was actually one of the big presentations at this meeting. We're all living in an era of COC 5.8. We're all taking our 3 mediastinal lymph node stations, 1 hilar lymph node station. We're submitting them separately. We're all fanatical. We're doing our synoptic reports. And Dr. Zhang and colleagues got up on the stage and said, hey guys, we don't need to take out nodes anymore.
Yeah.
Leah,
Yes.
tell us about this trial. Tell us about kind of how they ran it, what they looked at, and what the conclusions were.
I was really excited for this trial, which is kind of sad. Like surgeons shouldn't be excited about doing less surgery, if you will, but I think it was something that really needed to be done and that they
Yes.
did it really well. So, they had patients who had extremely early disease, right? Because these were patients with minimally invasive adenocarcinomas or adenocarcinoma in situ, not pure GGOs necessarily, although they did include some, but basically they had to have a GGO, ground glass dominant nodule with a consolidation to tumor ratio less than 0.5. So I thought that was actually pretty generous as well, which is really good. And then a maximal diameter of less than 3 centimeters. So I think that their criteria for inclusion were completely reasonable and things that most of us can wrap our heads around and kind of get behind. And then they randomized patients as to whether or not they were going to get a lymph node dissection or no lymph node dissection. And by that, it's just mediastinal nodes. So the hilar nodes were still optional, if you will, such that, this at surgeon's discretion, they examine the hilum and see if there were some nodes that looked like they needed to be taken. And if so, then they took them. For those who had their lymph node dissection, it was prescribed for right-sided tumors. They have 2R, 4R, 7, and 8. For left side, 4L, 5, 6, 7, and 8. And then level 9 for any lower lobe tumors. So pretty straightforward. And they found no nodal metastases.
In any
Which is
patient, not
fantastic.
one.
I mean, which is pretty amazing. And the only the other strength, if you will, of this study was the fact that they had really nice outcomes, which is, hey, we're actually doing harm? Are we doing harm by doing unnecessary? It's one thing to have something unnecessary that you're doing, right? You're doing a nodal dissection for someone that's not going to add any value for them. But are we actually harming people? Like, is there actually additional risk, etc.? And I wouldn't say that it said that by any stretch of the imagination, but your operative time was much longer, 74 minutes versus 109 minutes. That's significant, that means if you shave that much time off of a couple of cases, you get to do another case in that room. EBL was lower, chest tube days, length of stay, basically all of the perioperative outcomes that you would consider. They did have one major hemorrhage from an SVC injury, which was interesting to note, as well as a chylothorax. But I mean, I think that this study is incredibly important and very timely, especially in light of our sublobar trials, that have been the new cornerstones for surgical therapy now with the JCOG and the CALGB. So super timely, and it will be very interesting to see how this takes hold in practice for people.
Absolutely. I agree. I think it was an elegantly designed study. I think they implemented it very nicely. They had planned interim analyses, and actually they stopped it early. They actually terminated the study early because they had no nodal involvement and they had actually concerns about non-maleficence, which was really interesting. And a well-given presentation. For anybody who has an opportunity, please make sure to check out that abstract and presentation. It was a great one.
Yeah, I forgot to mention that predetermined safety interim analysis. I think that is pretty important anytime we're talking about interventions and again, not wanting to do harm to any patients. I thought that was pretty nice that they put that in there a priori.
Absolutely. Important for any sort of new technology, procedure, drug, anything we're doing, we should always think about those interim analyses as sort of a safety checkpoint.
Absolutely.
All right, so $1 million question, Leah. What are you doing? Patient comes into your office tomorrow. You're taking them to surgery. They've got a GGO. It's maybe a GGO dominant adenocarcinoma, so subsolid lesion. Are you taking out lymph nodes?
I'm not.
I love it.
I mean, I kind of feel like I was already there.
Yeah.
So maybe that's why I like the study so much, because it kind of validated my current practice. But it's funny because at least one of my partners was the complete opposite and would start off every resection, every wedge for no matter how small and peripheral or ground glassy with their nodal dissection that they would freeze and only commit to the wedge if indeed it was negative. So it was definitely a very purist, approach. But yeah, I was kind of already there. What are you doing?
I love it. You know what? So for me, this is actually going to be a change. So I was, subscribing to the COC 5.8 guideline. We're part of the initiative and the quality improvement project. And this actually gave me a huge amount of pause because it makes a lot of sense. If I think about my own practice and the patients I take care of, I couldn't think of a single patient who had surprise nodal positivity meeting the inclusion criteria of this study. Now, I will say that, especially because I tend to do a lot of segmentectomies. I love segmentectomies. You get a lymphadenectomy just by virtue of doing a segmentectomy, right? The lymph
Sure.
nodes are covering
Yeah.
your
Yeah.
veins and your arteries. And so you're going to get a lymph node yield
Hmm.
in sort of those tumor draining areas. And so, I sort of feel better about the fact that theoretically, if there was that 1 in a million person or one
Yeah.
in, 200 and whatever person that somehow managed to have a node, that I would catch it. But yeah,
But
no,
I
this
don't
is,
think
this is gonna be a
this
practice
changes
change.
your praxis though. If you're doing segmentectomies, you're getting N1 nodes, right? You're
Yes.
not getting N2 nodes. And so I think this is completely in alignment with that and doesn't really require a major paradigm shift. So,
Absolutely.
but I do wonder what is going to happen
Yeah.
to your next COC audit, right?
Mhm.
How are we going to recognize these two divergent principles? I honestly don't know. Even now, I think it is difficult if you examine a nodal station and there's no node to be had, like say there's no level 9 node, you didn't find one, right? Okay, well, that's one less station that you're going to be credited for, despite the fact that you looked for it and dissected for it, etc, because the COC auditors are only looking at path reports. They're not looking at your operative report that says you did all this amazing stuff. They're just looking to see what the specimens are.
Absolutely. Well, and shoot, if you're going in for a revisional surgery or, a recurrence or
Yeah,
something down the line, I hate going back in on one of my own cases 5 years later. I know there's going to be no station 9. I know there's going to be no station 7 because
right,
I took them all
right.
out.
Or if
So,
it's not safe, that everything's very fibrotic and you're like, I really, I don't think it's safe to keep digging around in this, subcarinal space kind of thing. You don't get credit for that.
yeah, absolutely. So I think, very interesting time. And I think it also highlights the importance of incredible projects like this, bringing all of that data back home, back to our societies as quickly as possible, and then working together to find a solution of how do we incorporate all of this great new data into practices. And especially, when we think about things like the COC guideline, do we need to adjust and say, hey, we only need to meet that full lymphadenectomy and XYZ percentage accounting for these patients that are not going to need it anymore?
Absolutely.
All right, so Leah, we're going to go full circle back into perioperative again. We're going to talk about one more trial. This one is called Keynote 671. So a lot of people are familiar with Keynote 671. This was really one of the first major perioperative trials that came out. Really a lot of excitement and buzz around it. As a reminder for our listeners, this was a 2-armed study. So we have our chemo versus chemo IO, this time pembrolizumab delivered in the neoadjuvant setting. A little bit different from the Checkmate 816 in that this time we're giving 4 cycles of the chemo IO. And remember, we did use cis as the dominant backbone for that. And then we go on, just like we did in the other trials, to have surgery. And then these patients did have either placebo or pembrolizumab on the back end. And the important thing to remember is that in the Checkmate 816, it was up to the treating physician if any adjuvant therapy was delivered. For this one, it was recommended that the patients undergo that additional adjuvant arm. And actually, a high percentage of them did go on to complete that. Just like with our Checkmate 816, we did see a beautiful EFS benefit. And actually, this was the first trial to show an overall survival benefit with this perioperative regimen. So a lot of excitement. At this particular meeting, we're getting some 4-year updates. And so things like our EFS, our OS, our MPR, PCR subgroups, but specifically looking at patients in subgroups of nodal positivity. So were they coming in clinically node negative, node positive? Were they N1, N2 at baseline? And how did that impact our overall outcome? So Leah, give us the details on that.
Well, yeah, basically, just as you said, this was looking at the results stratified by node status. So either clinical N0 or clinical N1 or N2 disease lumped together in one group. So it's basically just positive versus negative. And then looking at the results stratified by treatment arm, pembrolizumab versus placebo, and pretty much consistent with the outcomes from the parent trial or from the entire group, if you will, in the non-stratified data, such that there was improvements in EFS and MPR and PCR and the pembrolizumab group or arm for each group, whether you were node negative or node positive. The outcome of overall survival was not reached yet, which is nice. But this is 4-year data, as you said, so this is a nice update, and it just goes to show that we're going to have some more abstracts coming out of this data. But I think it's really nice. Again, it's somewhat similar to the other update on the Checkmate 816 data that we were looking at with regards to extensive surgical resection, which is this is another example of looking at the data through the lens of a different strata to determine whether or not we're really benefiting all comers or certain subsets of patients. The takeaway from this is pretty clear, which is just that whether you're node negative or node positive, you're still going to derive benefits. So it wasn't necessarily comparing the magnitude of the benefit, whether you were node negative or node positive, but it demonstrated that the pembrolizumab group was associated with an improvement in all of these parameters compared to placebo in each of those node negative versus node positive groups.
Absolutely. And how exciting that we actually get to talk about 4-year and 5-year survivals, not even crossing that 50% mark with these new treatment. I mean, it's just so incredibly exciting, isn't it?
It really is. I mean, just the pure explosion of positive data within the lung cancer space is just amazing. I mean, I feel like for the longest time we were sort of the redheaded stepchildren, if you will, in the oncology world, where we just really didn't have any movement when it came to very little movement when it came to our survivals. And now, yeah, we're talking numbers, putting up numbers out there that had never before been discussed in this arena.
I think the other big take home message that I feel that I'm getting from a lot of these trials is that, historically we sort of shied away from N2 disease, right? We didn't know, is single station okay? Is multiple station okay? Where did surgery exist in this N2 world? And we see coming out of Checkmate, out of Aegean, out of Keynote, out of Nadim, all of these trials out of NeoCoast, that we are really effectively controlling disease with these perioperative regimens, with these neoadjuvant regimens combined with an aggressive local safe surgery. And that's the key thing, right? We need to be providing really highly effective, safe surgery, just as you've mentioned before. And so, I think there's a lot of things coming onto the table now, and I think we are actually expanding our cohort of patients who are candidates for surgery now.
Absolutely. I mean, it is really common for us to talk about patients with 3B disease now, whereas, we kind of barely talked about the 3As before. Now the 3As is kind of like old hat, and we've moved on to 3Bs, and how it is that we can be able to offer them multimodality treatment is really exciting. I do like this study and sort of looking at the clinical nodal disease, because that's where all your decision making is happening, is up front. It's nice to look at things post surgical, right? And look at, all of your pathologic or post resection indicators. But it's also important to be able to rest your hat on things that you will have in real time as you're prospectively treating somebody. You're not going to have their path CR rate, right? You're going to have their clinical nodal status, and that's what you're going to have to make decisions based on.
Yeah, very pragmatic sort of analysis.
Mm-hmm. Yeah.
Yeah, I love that. I love that. incredible group of presentations, of articles. And honestly, I think it's important to make mention that there were so many great presentations, so many incredible pieces of data that came out of the World Conference this year on lung cancer. And we could probably go on for frankly, another hour. But
just to be clear, we could not go on for an hour. You, Dr. Gillaspie, could go on for an hour. I think I just want to take a second to just put a huge plug in for you and the fact that surgery, and specifically thoracic surgery, needs champions like you who help straddle both worlds between the surgical world and the medical oncology world to help build bridges, because it's just overwhelming. If I had to be a thoracic oncologist right now, I don't see how I could do it. And the fact that you have such an amazing grasp of all things happening thoracic, thinking thoracic, um, in addition to all of your surgical technical knowledge, is amazing. So kudos to you, and thank you for bringing this to all of our members.
Well, thank you. It means so much to me to have this opportunity, and I'm so grateful for it. It's something I'm passionate about. And well, I could just, I could talk forever about all these things.
Yes, you could.
So, Leah, in the last few minutes we have together, let's connect this back. We've talked a lot about sort of real world take home messages for our thoracic colleagues as we think about being, important members of our multidisciplinary team. So if you can sort of boil down a few key take home messages for everybody today, what would those be?
Well, I would say that we've got a new kid on the block potentially with TIGIT as a potential new molecular target. And so keep that in your brains as something that may be coming up. And we'll have to do all the due diligence to make sure that this is going to be also a safe agent to be used in the perioperative space, et cetera, and duplicate all the data that's already been out there for all the PD-L1s and TKIs. So TIGIT, be aware that he's a new kid on the block. The other thing I would probably collapse things down is to say that there are very reassuring data from the neoadjuvant trials demonstrating safety and efficacy across various subpopulations of patients. So independent of nodal status, independent of surgical approach and extensive resection, that we're going to be able to do a lot more surgery and do so safely, independent of whatever it is that our patients are going to be getting. So there's still benefit to be had. And then the last one, of course, is the lymph nodes. So you don't need to go and do your mediastinal lymph node dissections for these very small GGOs or predominant GGOs that really think about whether or not that's necessary. I mean, obviously, if there's something that looks funny or weird about a node or whatever, use your best clinical judgment, but the likelihood of your finding something is incredibly low, and you may be saving your patients some added morbidity by avoiding that.
Absolutely. Incredible take-home points. Thank you so much for joining us, helping to translate these findings into wonderful surgical insights.
Thank you, Dr. Gillaspie.
For our listeners, you can find more information and related resources at sts.org and in the show notes. Until next time, I'm Dr. Erin Gillaspie, the podcast host for the Society of Thoracic Surgeons. Follow the 2025 Best of Lung Cancer Science podcast special edition series, now available on all popular listening platforms, including Apple, Spotify, and iHeart. And don't forget to follow me on Thinking Thoracic, an STS podcast that offers candid conversations about the latest advancements and challenges in thoracic surgery. The podcast is also available on any of your listening platforms. And as always, keep smiling.